that works in the administration suite as well as Michelle. And so I'm teasing by calling him Sydney. So I'm Rachel. I am the CEO at Madison. I grew up in healthcare as a nurse. So my undergraduate and my graduate degrees are in nursing, in education, and in clinical. And one day, I just thought, you know, it'd be really cool to be a CEO. Honestly, it has to do with when you get into healthcare, you find that there's a lot of changes going on. It has always been that way in healthcare. Our conversations today, when we get it up, will obviously show how healthcare is significantly changing during your time. So what we're going to talk about today, we'll have two quick slides, or our YouTube videos, that's the word I'm looking for. And one is about healthcare reform and where we are currently. And then the second one is a video and a YouTube of where I want to hopefully plant some seeds with you to think about the future of healthcare. Because the way it is today is not the way it needs to be in the next 3 to 5 years. So that's what we're going to address. All right. Oh, I got it now. I think so. Okay. And honestly, okay, tell me timeline on here, because I can talk forever.
If you are done, 5 minutes till 3.
Okay. So as we go through this, the easiest way is for you to just raise your hand and interrupt while we're going through it to ask the questions, because there's so much topics that we'll be going through, and when we get to like slide 4, you may forget what slide 1 had, okay? All right. So, excuse me. This is healthcare now. Does anyone in this room think that the way healthcare is running is sufficient, effective, great, no worries, USA, go all the way, we should get a gold medal? Why not? You have some answers, but in a general standpoint.
It's just we have so many resources here in America that I believe are underutilized, lots of uninsured, just lots of messy government regulations that just, it makes it hard to progress forward, so.
Agreed. And you, yes?
I feel that some of the models that are coming out now for health care as one, among other things, doesn't teach and educate us for self-reliance.
Very good. I want you to tell everyone that one. That right there in of itself would change healthcare a lot.
I'll take any job you're
Yes.
And to piggyback off of that, what healthcare does right now is fighting after a problem already happens, instead of working on preventative medicine, which would be ways to lifestyle changes of Americans.
Yeah, you know, and it's not addressed in here, but very topically, addressing some of our societal issues on how we approach healthcare is nowhere near or not even touched in the Accountable Care Act. And so even though this is a good approach to a first step, it isn't addressing what you're talking about necessarily. It isn't addressing how do I, as an individual, have a responsibility in my own health. Because right now in our country, we do have a country where, I might get we were talking about this, the fast food company lawsuit wrong, where they sued them for the hot coffee.
McDonald's.
But McDonald's. Hot coffee, you know, kind of know you're going to get burned, but still, our whole society is behind I can sue because of that concept. And you apply that to healthcare, and you can just really magnify that by millions and millions of dollars. So, all of these, I'm not going to read them all, but you kind of touch these. We have a lot of problems with our payers. We've got, we'll talk about the costs a little bit more. We're expensive. Anybody in here had a baby, or you know, had to use our emergency room, go to the doctor? It's expensive. And you know, honestly, Madison is pretty good at controlling costs, and we're pretty good at keeping the costs low. We are fortunate as a county hospital to not need to send money back to corporate. Again, there's a lot of good things of having a corporate healthcare system as far as efficiencies, but our costs are low, but it's still expensive. It still is an ouch out of your pocketbook, right? Okay. Questions on any of this? Any of it, anyway? No. Any of it shocking or? Okay. Like I'm pointing at you, Michelle. All right. Other than Sid and Michelle, can't answer this because both of these know the answer. Actually, maybe I should test it in front of all of you guys. What does this say to you? Does anyone know what this means? I'm going to go to someone who didn't raise their hand. No offense. Yes, please.
spending on healthcare is increasing
Okay?
from a rate of 3.8 of GDP in 1935 to an estimated rate of 25 GDP in 2025.
Okay, do you guys understand what that means? Is that sustainable? That's what you've heard. That's
No.
staggering costs. That, as far as, I mean, what about education? What about our defense? I mean, you could just go down the whole list of things. I mean, obviously I believe healthcare is pretty important, but do I believe that healthcare is this important compared to what I want my kids as far as education? No. Should it be that expensive? No. Can you go to other countries and get it less expensive? And is it that percent of their countries? No. What about this number? Can you guys see that back there? It's
17 trillion.
17 trillion. So I gotta use someone else's analogy here, and Sid helped me remember the analogy on this one. But he explained, when I think of trillions of dollars, it's kind of like monopoly money. You know, honestly, how many of us are gonna see $1 million in our lifetime, right? So when you start thinking billions and trillions, it's sort of like monopoly money. It's sort of hard to figure how much that is. So the analogy we have, tell me if I get this right, Sid. Think of $1 million as a marble, okay? Then you think of $1 billion as a basketball, okay? So what do you think a trillion is? It's a hot air balloon. Well, we're 17 trillion in debt, our nation. Now there is also, yeah, is that not humbling? That is extremely scary and humbling. And then when I've been at some recent conferences, there's some argument back and forth about this is actually underestimated. And there's a reason why I believe that. Sometimes I'm pessimistic, it's not that. In healthcare, we'll try to do things when we're communicating things, and we try to communicate them to the public in a half-glass full type of an approach. So if we're saying, hey, there's an influenza outbreak, we don't want you to bring your kids into the medical surgical unit, you know, whatever it is we're talking about, we try to portray it as, you know, I don't want you to bring your kid there because I don't want the kid to get sick, and it's a great thing. Instead of, did you know what happens when you get influenza, and go that negative side. So I think the reason why it's underestimated is because they don't want to scare us. Well, it scares me anyways. So far, does anyone have any question just from this? This is really the tip of the iceberg, that healthcare needs to change. Or it can't stay the way it is because then it'll just implode. No? Yes?
So for this national debt, you know, a huge chunk of it comes from healthcare. And it's because of what we were talking about before, all these entitlement programs we have with, you know, Medicare and Medicaid and Social Security, and now the Affordable Care Act is just adding and adding to our expenses.
Yep.
But people have become dependent on that as well.
Yep.
So, I mean, I don't expect you to really be answer to this, but I was wondering your thoughts. How do we somehow get this sort of under control without taking
We're going
away
to
what
exactly
everyone's
there.
depending on?
So hold on to that
Okay.
and ask the question again if you have more, because that's a perfect question. Someone else have the good one. Yes, please.
So if this is what you believe, what are you and your team doing in your hospital to combat this? Like, where
Hold
are
on
you?
to that one too.
Okay.
I'll go on. Perfect questions. We will go on. Okay, so this is, I don't remember, this is 9 minutes, 5 minutes, can't remember how long this one is. Okay, I'm going to talk about this while you can go back a slide and let Sid play with the video. What they're trying to get at is, and if you can't find it there, Michelle, go to Kaiser Foundation. Okay, we're going to talk while they're playing with the IT stuff. Go to Kaiser Foundation, Healthcare Reform or Accountable Care Act. Okay, they're going to pull up, it's a cartoon. And the Kaiser Foundation, have you seen it?
Yeah.
I think it's a good cartoon. And it explains the Accountable Care Act. And maybe, okay, I do like cartoons. I love all the Pixar shows. So besides that, I think it takes it from such, I mean, that document and the roles and stuff in that are humbling, and they are overwhelming for even the smartest of lawyers that like to read that kind of stuff. But it takes it to a level where, what does this mean to me? So that's what we're gonna try to pull up, is as far as Accountable Care Act, what does that mean? What does that mean to you as far as insurance? So that's what we'll take a look at. The slide that was before that, and I think what you saw, or after that, excuse me, I'll talk about it. It was a slide and it showed a basketball team and how the different players of the basketball team. That's what healthcare is now. So I'm the nurse, you're the physician, you're the surgeon, you're the patient, you're the insurance company. You have all these players involved in healthcare, okay? Well, we don't really have to talk to each other. We can all do what we want. I mean, I'm the nurse, I need to follow the physician's orders. We can kind of go about our jobs independently. Doesn't matter how well we take care of the patient. You know, if we make a mistake, we could get sued, right? But let's say we don't really fix the issue, or it's a bad outcome. Guess what? Every person right there just still got paid. Right?
Yeah.
That's what fee-for-service is. So we're a volume-based. So right now, when you come to Madison Memorial Hospital, we get paid for every test. Well, not every. I mean, it gets a little more complicated. I'm generalizing things here. But we get paid based on every interaction or every incident or encounter that occurs at the hospital. Each player involved, like a basketball team, gets paid. Only one person has the ball at a time, but they don't have to coordinate everything. Okay, now I don't play basketball, so I probably have off a little bit, but the way that they're trying to convert things from a fee-for-service or a volume-driven healthcare to what's called, do you guys know what it's called? Capitated? Close.
It's the new quality program being implemented, and
Say it louder.
the new quality program being that Medicare's adapting, that says your payments are now based more on patient reviews rather than lump sum or fee-for-service.
Yep. So it's going from a volume, so how many times I poke you, how many times I perform a surgery on you, how many times I do that, to a value-based. How well did I do that? Was I kind to you at the same time? Did I have an outcome that was appropriate? Did you get your appendix out and it fixed the problem? It's moving to that direction, which from my perspective, and I would assume anyone else that's had to put money in healthcare, wouldn't you rather pay for what you're going to get rather than just every incident and you don't necessarily know? The reason why it's so hard in healthcare is people aren't cars. So it's difficult because the way his appendix works and the way his works, there's still some differences. Let alone when you put women in the medication, because we're more special. It just complicates things. Each person is very different, and so that outcome is going to be, even though it's the exact same surgery, it's going to have a difference between the two. And so it's complicated. It seems simple. Well, why don't we do that in the beginning? Well, people are complex. Any success? Okay, I'll be quiet.
Well, it's finally happening. After years of drama on Capitol Hill, a Supreme Court case, a presidential election, and a Mayan apocalypse that could have stopped it dead in its tracks, but didn't, the marquee elements of the Affordable Care Act, sometimes called Obamacare, are about to kick in. And big changes are coming to health insurance in 2014. In the next few minutes, you'll get a pretty good lay of the land by once again watching your fellow Americans, the U-Tunes, find their way through the system. There are 4 main ways nearly all of us will experience health care once the health reform law goes fully into effect. About half of us will get insurance through our jobs, just like today. About a third will get covered by the government through Medicare and Medicaid. About 1 in 10 will buy insurance themselves. And unfortunately, another 30 million of us or so, just under 1 in 10, still may not have coverage at all. But let's begin in the workplace. Many Americans are already covered by their employers, and for them, not a whole lot will change. There will be some new advantages, though, like caps on how much you have to pay out of pocket, and free preventative care. The bigger changes are coming for those who work for larger companies but aren't covered now. That's because the government is going to require companies with 50 or more employees to cover full-time workers or pay a penalty. So more workers may find themselves covered. Smaller employers won't face the same penalties for refusing to buy insurance, but they'll be encouraged to do so. The government will be setting up special marketplaces to make it easier for small employers to take the plunge. Some will be offered temporary tax breaks if they do. And unlike now, insurers can't inflate prices if some employees are sick. So many of us will be getting covered at work. A lot of us will be covered with help from the government, just like today. Not much will change for seniors on Medicare. The law has already started helping with prescription drugs and better preventative care, and that will continue. Medicaid, on the other hand, is expanding to cover more of us, especially poor adults, many of whom aren't eligible today. If your income is low, Medicaid will cover you, most likely in a private insurance plan. But there's a catch. The Supreme Court ruled that governors and legislatures of each state should decide whether or not to be part of expanding Medicaid. In states that get on board, the feds will cover almost all the cost. But for those who don't, you may be left with the same options you have today if you're poor. So you'll want to check out your state's decision if you think you might qualify for Medicaid. Even with employer coverage and the expansion of Medicaid, a lot of us will still be left out. For those not covered or who find their work coverage too expensive, a new way to buy insurance on our own will be popping up everywhere. They're called health insurance marketplaces, though they may have a fancier name than that in your state. The health insurance marketplace is like a virtual insurance mega mall. Here you'll find private insurers competing for your business, and you'll be able to pick out how much coverage you want and how much you want to pay for it. From cheaper, high-deductible bronze plans to more expensive platinum plans. Still, all plans will cover a comprehensive set of services like hospital and doctor visits, paternity care, mental health care, and drugs. Most everything any of us need, at least when it comes to medical care. As with Medicaid, not all governors are on board to set up these marketplaces, but the feds will open their own in those states, and so you probably won't notice much of a difference. One big advantage of buying insurance through these new marketplaces is that the federal government will provide most people with a tax credit to make insurance more affordable if you don't have any other options and your income is below a certain level. In fact, most people buying on their own will be eligible for a tax credit and won't have to pay the whole premium themselves. And the marketplaces will make sure that insurance companies operate fairly under strict rules. They'll have to offer everyone insurance, even if they're sick. And they won't be able to charge more for pre-existing conditions. Unlike today, men and women will pay the same price. And prices for older people will come down, while young people will pay more. To keep costs down for young people, though, they'll be able to stay on their parents' plans until 26. And buy low-budget catastrophic plans until they're 30. Of course, all these changes still don't mean insurance will come cheap. Most people buying their own coverage will end up paying less with the new health insurance tax credits. But some people will have to pay more, even though many of them will be getting better and more secure insurance. So let's be realistic. Not everyone's going to run out and buy insurance. Some might say, hold on a minute. If I can't be turned down or charged more, why not just wait until I get sick or injured to buy insurance at all? Well, first, you can only get coverage during special enrollment periods. So if you snooze, you may lose. And second, thanks to something called the individual mandate, if you're not insured, you pay a fine, making this option seem not nearly so clever. Still, if you really can't afford to buy in and can't get insurance anywhere else, the government will waive the penalty, so don't panic. By now, you've probably noticed a lot more people will be getting a lot more coverage. Where will the money to pay for that come from? Taxes, many of them targeted at the health industry itself, even canning services. Yes, individuals will pay too, mostly the wealthiest Americans, who will be paying more into Medicare. Also, hospitals and insurance companies participating in Medicare will get paid somewhat less. Not painless, but somebody's got to pay. So, as Americans prepare for 2014, how will you be covered? How would you like to be? Now's the time to figure it out and get on the path to setting yourself up for the best insurance at the best price. After all, who wouldn't want that?
So obviously this was put out prior to the January 1st date for our insurance. I think, thank you for asking. So first of all, was there new information in here for you guys? Did it help convey it in a way that if you were to share it with I don't know, with your grandma, with your mother, with someone on the street, that would help communicate and help them understand? Probably a little better. It's obviously more pro healthcare reform than the Accountable Care Act. It talks about expanding coverage. It's got some good points in there. What is it not pointing out?
I'm guessing the cost to actually run the program itself.
Yep. Any ideas of what's going on with the costs right now in healthcare? It's going up. It's slow. The rate, that is a good thing. The rate of growth in healthcare spending and healthcare costs has slowed. Yet, have we seen a decline with that, or because of this? Not yet. Yes, sir.
I don't know if it's the correct answer, but it estimated that 30 million would be registered until they extended the deadline, and we know that the numbers, even as of early as the first of this month, are somewhere between 2 to 2.5 million. And there's states, including my home state, that are complete and utter failures. The state of Oregon does not have a system at all, and they would thought they were going to have one from the very beginning.
Well, the federal government, we know how that one went as well. It didn't go so well. Yeah. And our state, Idaho didn't, and Utah, our neighboring state, did not expand Medicaid. So as of yet, we have not seen an increase in insured. What we have seen is an increase in a person's deductible, to the point that it becomes a catastrophic insurance, meaning $15,000 before your insurance company will kick in. That's a lot of money. But that's some of the things that we've been talking about from some of our community members, that when they've gone into the insurance exchange and purchased some of these, you know, it depends. It's so individualized, and where you're falling, you know, as far as your parents, if you can qualify that way, if you qualify for Medicaid, if you don't. So it's all over the board, but some of it, not yet. But we're new in this process. Yes, and then yes.
I noticed that it said that there wouldn't be any changes made to Medicare, or the people covered by Medicare will still have the same coverage, which is partially true, but from what I understand, they cut a huge amount of funding to the Medicare Advantage plan, and so there's less options there, and I think there's a tax on higher income Medicare recipients and things like that, so there are some changes that they're making to cover their costs that they're maybe not mentioning.
They're also cutting reimbursement to hospitals for Medicare. And some hospitals and some physicians have chosen to get out of the Medicare business. And so right now, we'll even have some of our doctors who'll say, find me a neurologist that I can get my Medicare patient into within 6 months. And again, in fairness to the physician, it's about covering their costs. And so Medicare is one of the lower payers. Yes?
Like, has your hospital been affected yet with the whole, like, free preventative care and everything else yet?
No.
Or will it be affected, really? Too much?
You know, possibly, but right at the moment, given our population, we're in a pretty favorable market. So we have a lot of private insurance, we have a lot of people who have been coverage, we've got a lot of people with Medicaid, we've got, you know, the coverage that we have versus some of the other hospitals puts us in a good standing. Other hospitals, like I said, you know, I think I said North Dakota is looking at closing some hospitals this year. You know, so there's, it depends on your mix, and that's what makes it a little hard when you come up with a program for the entire nation. There's some differences. We're certainly different out here in the West than anybody from the East Coast here. Are we different in the West than the East?
Yes.
Absolutely, right? So it's kind of hard to mix and match and have one size fits all, but we'll see how it goes forward. Other questions on that video before we go on? I think you'll be excited by the second video in the future that I think this is kind of what we're dealing with now. I want to believe that there's hope if we educate the young ones, and the SIDS and everyone get out there and say, you know what, this is what we need out of healthcare. This is what I want my healthcare to look like. I'm on the video yet. Oh, this is a slide that I had for another, when I was talking with some of the community members as far as what hospitals need to do to make it through this transition from the volume base to the value base. So there's some obvious things that we need to do as far as lowering costs, look at some of those. You know, there's some, certainly a focus on switching from, we are a healthcare institution, but our business is taking care of sick people, except for having babies. So we're called health, but our focus is sick. There's something missing there, right? So that's a good thing. Mental health. We have so many patients that come through, and the access to mental health in our nation is abysmal. The percentages of the homeless that are actually those with psychiatric disorders is significant. If you took a look and you dived into the mental health system that we have right now, just go into some of the national stuff that maybe you saw in 60 Minutes as far as some of the gunshot victims, some of the different things that we've had. You look at it, they had access and they were in the hospital for different psychiatric treatments not long before something went wrong. So there's a governor, and I wish I could remember his name, and his son attacked him. You guys probably don't know.
Somewhere on the East Coast, Virginia, or
Was it governor or a senator or?
something on the East Coast, Virginia, North Carolina, something like that.
He's making it a mission to address this mental health. It's interesting. If you have a minute, take a look at it, pay attention to this, because it is something that is completely ignored because of that societal stigma, and we don't want to deal with some of those societal issues because I might want to get voted back in next term into my seat, right? End of life, that's a touchy one. Look at the way that we deal with end of life issues. If you're 95 years of age, you could still get a hip transplant in our country. Other countries, you say, had a great life, and why you have the hip transplant, but we're not going to pay for it. If you want it, you need to pay for it. Or we keep patients alive because we're worried about the lawsuits and the legal ramifications, and we need to get through all of that when we might be prolonging your life when you really didn't want your life prolonged in the way it was. Again, societal issues that are very uncomfortable for us to talk about in the United States and our laws, but those aren't issues. But these things are driving up significant costs in our country. Nothing in there in the Accountable Care Act. Questions on that? This is a picture of an old hospital in Chicago, and on an average, and I don't remember, you know, I have a CFO, the finance guy, he always remembers the numbers, so I always forget them, but on average, what's the number of empty beds? Do you remember, Sid? Per night? In Chicago, there's a 5,000. Oh, see, that's why being a CEO is awesome. You have people around you who remember things. 5,000 beds per night. Thank you, Michelle. That are empty. So Chicago has lots of hospitals. 5,000 of them, on average, per night, are rooms that do not have patients sitting in them. What does that mean to you?
That's bleeding more than the patients are.
It is. That's a lot of waste. It's a lot of waste. So if you got rid of 5,000 of those beds, so how many hospitals would you get rid of? How many costs? I mean, there's still lights. Even though there's no patient in that room, there's still a cost to have that room. That's right now. That was well before the Accountable Care Act. Thank you, Michelle, for that. Okay, this is a video of Dr. Eric Topol. Remember his name. He is a cardiovascular, he's a surgeon, cardiologist, and he has embraced the future of healthcare. And so this is, we're going to leave the past. Now we're going to look at where I think this just could give you a glimpse of where healthcare can go in the future if we want to make some changes.
How did you find out about that? At lunch, we pulled out what we were told is one of his weaknesses,
tortilla chips.
Will you partake?
Oh, yeah, it's hard to resist.
Okay, come on. Handful.
They are loaded with carbohydrates which trigger glucose.
Yeah, this is my guilty pleasure here.
So, out comes his cell phone.
I mean, I can look at my glucose every minute. I don't want to look at it every minute, but I can. And so I can just turn it on, my glucose. Fortunately, I haven't had enough chips here yet, but it's 107.
How does it know that?
Well, I have
Sorry guys, we're on video. Have you guys seen anything about him yet? No? You'll like this. Who has a smartphone? Okay. Who has a computer, access to a computer? Okay. He's kind of into, he's in, the Bay Area and San Diego with all the, IT gurus and stuff, so he's obviously into that. No. I can basically explain it if we don't have it. Because they can Google it later. We'll try one more second, if not, I'll just explain it to you and you guys can take a look at it later. No, that's not it. That's okay. But I want my smartphone. Okay. Just go to YouTube and type in Dr. Eric Topol, T-O-P-O-L, and you'll be able to look at all of this. Got it. He's better speaker than I am on this, so hopefully. Thank you, Michelle.
Up next, it sounds like science fiction. Dr. Nancy Snyderman reports on how your smartphone may change medicine, including warning you of a heart attack. Welcome back. In our next story here tonight, we're about to hear one of the world's top physicians say the smartphone may change his profession and personal medical care in ways none of us saw coming. His story tonight from Dr. Nancy Snyderman.
why do we have people being treated like cattle herd? That's waste. And the billions of dollars that's being wasted each year for screening and the wrong drugs and the wrong everything. It's astounding. And we just can't go on like this. Yeah, I'll take that. Thanks.
Dr. Eric Topol has long been one of the world's foremost cardiologists.
Hey, great to see you.
He has now become the foremost expert in the exploding field of wireless medicine. And this explosion, he says, is about to make our healthcare better and cheaper. Watch what he does with a cell phone.
And we'll just pop this iPhone into it like that.
He shows how simply his modified iPhone produces a cardiogram for a patient.
So you just put your fingers on it, and you go. And in a second, in the first second, then it stabilizes. There it is.
The device was approved by the FDA in December and is now sold to physicians for $199. Topol tells his patient he just saved a $100 technician's fee.
So are we close to using this to say, I'm going to diagnose you and prescribe 4 or 5 apps instead of 4 or 5 medications?
Well, these days, I'm actually prescribing a lot more apps than I am medications. You can take the phone and make it a lab on a chip. You can do blood tests, saliva tests, urine tests, all kinds of things, a sweat test through your phone. This is a powerful device. And we'll just have you hold that on there like that.
Topol's patient, Ron Thompson, is dealing with several significant heart issues.
When you saw that on a phone, weren't you just amazed the first time you saw that?
Yeah, absolutely. Just having an ECG machine hooked up to me and put all these, shaving my chest and stick them on there and put the electrodes or whatever. But yeah, no, this is incredible.
Topol also uses a portable ultrasound, a V-scan, to image Ron's heart.
So, get a good window. Oh, there's aorta, and you see it is dilated.
The V-scan is made by GE, a parent company of NBC.
Can you see that? See how strong that is coming together?
He does in the office what would normally be a separate test costing $800.
There's over 20 million echocardiograms done a year. So 20 million times $800, that's a lot of money. And probably 70–80% you can get rid of just by having this part of the physical exam.
I was surprised when you saw Ron that the technology did not get in the way of the doctor-patient relationship.
Actually, what I think it helps make the whole interaction much more intimate, because now I'm sharing the results in real time. There's so much technology now that we could, by using the digital structure that exists today, that we could make the office visit an enjoyable thing. And not only that, Nancy, but it doesn't have to be in person. There's no reason why a lot of office visits, if not most, could be done remotely.
Ron could take his EKG at home, send,
Yes.
and
Oh,
boom,
yeah.
you have
We'd
it.
be looking at it together. Or if I got him a wireless ultrasound, and he just puts it right there, and I just say, okay, take a deep breath, I could be watching it in real time. I mean, anything that we do can be done remotely.
When Topol came to Scripps in San Diego from Cleveland, he started a new chapter in his life.
When you moved here in 2006, you had just left the Cleveland Clinic under not very happy circumstances.
Right.
He had a reputation for brashness. It questioned the safety of the hugely profitable painkiller Vioxx and eventually forced it off the market.
I resigned from that after having been there 14 years. It was a significant part of my career.
Do you think, wow, I've done a really great job making healthcare better? Or do you think, damn, there's so much yet to do?
I feel the damn there's still so much to do problem. I feel that big time.
Do you ever think about how you're going to die?
Yeah, I do. Sometimes, I watched my mother die at a very young age, in her early 50s, with leukemia, and my father was an end-stage diabetic, and he went blind at age 49.
Topol uses DNA testing and monitoring to pinpoint his specific vulnerabilities and guide his daily life. He refuses to use elevators, and his day is spent walking from building to building. He incorporates an hour of exercise into virtually every day, no matter how busy, trying to live the life he thinks we'll all be living in the near future.
How did you find out about that?
At lunch, we pulled out what we were told is one of his weaknesses, tortilla chips.
Will you partake?
Oh, yeah, it's hard to resist.
Okay, come on. Handful.
They are loaded with carbohydrates which trigger glucose.
Yeah, this is my guilty pleasure here.
So, out comes his cell phone.
I mean, I can look at my glucose every minute. I don't want to look at it every minute, but I can. And so I can just turn it on, my glucose. Fortunately, I haven't had enough chips here yet, but it's 107.
How does it know that?
Well, I have a sensor on.
Where?
And, I have it on my abdomen, but I'll show you what it looks like. It's like that, touching the skin.
So that sends a wireless signal to this.
Yes.
And if you were a diabetic and you had this, you could then send this message to your physician or to your computer,
Oh, yeah.
and you could start to see triggers and trends and follow this.
Sure. Oh, yeah.
And there goes the lifestyle change.
You got it.
Eric Topol is a man who looks way over the horizon, and everywhere he looks, he sees a cell phone.
In the future, let's assume I have heart disease. What could this tell me about impending trouble?
Well, we're working on a project that will take a nanosensor in the bloodstream that's smaller than a grain of sand, and it will pick up a signal when you have cells that are coming off shed into the bloodstream, coming off from the artery lining, which is the precursor to a heart attack. And then you will get on your phone a special heart attack ringtone, which will warn you within a week or 2 weeks that you are very liable to have a heart attack. I know it sounds a little invasive, putting this little tiny, smaller than a grain of sand in your blood, but what that will do of having your body under continuous surveillance, talking to your phone, that's the future of medicine. So this is a heart rate.
This is his newest passion, the Visi Mobile Wrist Monitor. Topol was involved in its development. Everything a hospital intensive care unit now monitors, this does wirelessly.
So if my 90-year-old father is discharged from the hospital, it's conceivable he could go home with something like this and a doctor could monitor him remotely?
Absolutely.
His book lays out how the digital revolution will create better health care.
You write in your book that medicine is currently set up to be maximally imprecise.
Yeah, medicine today is about as much wasteful as one can imagine. So let's just take drugs in this country. Prescription drugs. 350 billion a year, a third of which is total waste. We're giving a drug that doesn't work. In fact, even worse now, we're giving drugs that backfire with side effects. So that's 100 billion plus just from the prescription medication. And then what about mass screening? every woman should have a mammogram every year, colonoscopies, PSAs. It's really medicine dumbed down. It's treating all human beings the same. That's crazy. Well, each of us are truly unique in every way.
What is the patient of tomorrow looking
Yeah, the patient of tomorrow is the biggest switch. People need to take ownership. They need to seize the moment and seize the data. The new medicine is plugged in to you. It's understanding you, which we've never really done before. And you drive it. You got the data and you got information that you never had before. Wouldn't you like that information? Most people would. And wouldn't you like to be helping to call the shots?
Fascinating story. Our thanks to Drs. Topol and Snyderman for that. Up next here tonight, it's been a blazing...
Impressive?
Yeah.
So I was fortunate to meet and listen to Dr. Topol on Saturday and talk to him. And the chip he was talking about, he had it with him for the heart attack, and it literally is like a little tiny little microchip on the tip of his finger that he pulled out. And literally, you put it in the bloodstream, and then it monitors when the plaque is going out. So I forget the actor's name. Some Italian, plays Italian mafia guys. He was on vacation in Italy, and he just had a heart attack not long ago. I don't know what his name is, but played Italian mafia dudes. Anyways, obviously I don't watch enough of those to know his name. It wasn't Brad Pitt, so I didn't get it. That gentleman, that actor, had a echocardiogram, a stress test, and all of his labs within weeks before his massive environment died. Now, Dr. Topol said to me, or said to the audience, that if he had this chip in his bloodstream, because there's a difference between knowing how your plaque in your bloodstream is starting to close off, what we can test for with the lab test and the echocardiogram. There's a difference on measuring that, and then when all this little plaque starts to break off and starts to fly through the bloodstream and causes that massive stroke or that massive MI. So if he would have had that on and the technology was proven and it rang his phone, he would have known that he was going to have a heart attack within the next couple weeks. He could have potentially gone into the hospital at that point and had what's called TPA. It's a thrombolytic, and it goes into the bloodstream and it dissolves all that stuff. Very expensive, so you don't want to do it preventative, lots of risks with it. But the point being, he could monitor and have that information instead of 3 very expensive tests that he had gone through that didn't save his life. So where should healthcare go? Well, told you I started out as a nurse, so I have a bias. I did get my doctorate in management, so I have crossed over to the dark side, if you will. But I think healthcare needs to go back to the patient. And I think it needs to get outside of the hospital, and that's what Dr. Topol will talk about. The hospital should be there, and we want to be there for you when you need to be there to deliver your baby. We want to be there when you have a motorcycle, I almost said. Joke, private joke. A motorcycle accident, whatever it is, we want to be there for when you really, really need us. We're going to be awesome if we're only there when you really need us, and there's ways that we can move to this preventative. Now, why, I'm going to throw this out there, why would, if this technology is here, and he just touched very lightly on some of the technology that, by the way, has been out for a while, why isn't it out there being used yet? Any ideas? Yes?
It might partly be because there's not much of an economic incentive for it. I mean, we probably have a lot of technology if there was an economic incentive for it. You know, hospitals want to make money, and if they're not, people aren't in their beds and they're not making money.
Exactly. You have a thought?
You also have other big power players, the $300 billion drug companies that are in every physician's office or in every hospital, however many times a month, plugging the Vioxx or the dioxins or whatever they're doing.
Yeah. Yes?
I think some places like Rexburg and places where I grew up in, they're not as technology advanced as a lot of other places like New York or Chicago or other places that have technology through the roof. And we're still trying to pick up on the latest trend. You know, but that's another thing that goes into it.
Okay.
Mine would be more of a question. How is the standard of care caught up with this technology? Like what? So, you know, if
Okay,
we can't
it's
apply that
starting.
standard care.
It's starting. So he had the ultrasound machine by GE. So, you know, I thought that was really cool. And Dr. Topol didn't say it here, but when on Saturday, he said as a cardiologist, he has not used a stethoscope in 4 years. In 4 years, he uses the ultrasound thing. So why am I going to come up, I don't know why I keep picking this guy. Why am I going to listen to his lungs, his heart, when what I'm really looking at is what's wrong with the heart? So he would listen with a stethoscope, which is 100-something years old, when it was invented, but a long time ago. I would listen to his heart. I try to, loved up, right? Try to figure it out, interpret it, say, that's off a little bit. Let's send you for the echo. Let's do that. Bypass all of that. Look at it. I don't have to guess whether the love dub is right or wrong. I'm looking at his heart and interpreting the information real time. Again, he's a cardiologist, and that's what he was using as the example. There's examples for labs. There's obviously the diabetes piece. There's a lot of this. Now, where I think that it will break through, because when I had the chance to talk to him, I said, you know, what I'm worried about is, you know, you come up with these, I don't know what the cost of the ultrasound machine is, but let's say that I want to go buy that for Madison Memorial and all the physicians. Let's say it's $10 to make that. I want to go buy that for all of our hospitals. I have to have it FDA approved. I'm going to have to go through an approved vendor. I'll go through that vendor, and what are they going to do to that ultrasound machine?
Mark it up. 400%.
Exactly. So that low cost ability, even though it could be like you talked about, it's a shift of the cost in the economy. It isn't just looking at it from the standpoint of how can we lower that cost. You just shifted who got the money. It doesn't necessarily shift it to, I just saved you money. So where I think that will come into play is if the public demands this. And if the public starts getting more and more educated about healthcare, and the public says, no, you have a right to have an effective, quite frankly, I think that would be a better treatment at a lower cost. Well, poor actor that I can't remember his name, obviously he's a great actor, who died, probably would have loved it if he had a doctor who had that ultrasound machine, let alone, he probably would have paid anything and could have afforded it. So I think it comes in educating and looking at healthcare in a whole new way. And this is just one aspect. This is what you can walk out of here today and do. So, you guys familiar with the food pyramid? Right? So, in essence, you gotta eat food, right? You're not supposed to eat too much. You're supposed to eat mostly fruits and vegetables. So here's the analogy for healthcare. We need healthcare, right? We all need healthcare. I need healthcare, not sick care. You don't want to get it too much, because guess what? It's going to cost a lot. And you want to get to your primary care physician. Don't go directly to that specialist because they are more expensive, and you want to look at preventative. Okay, now I'm going to open it up and see if there's questions from all of that swimming around or other questions. Yeah.
How does the new technology affect, I was in a class earlier where we were told as this generation we are more technology savvy, we embrace technology. But we're also looking at a baby boomer generation that's 40 million, that's expected to have an extended lifetime of 10 years. How can they relate and appreciate it? And how can, even then, if you are asked to do it, as I mentioned earlier with Medicare payments, if the Medicare isn't accepted, are you going to have a dual system going on where you're still going to have the stethoscope and still have the ultrasound machine?
Probably for a while. In the reality, probably. I don't see us going to a one-payer system. We've been talking about that. You know, are we going to end up with a one-payer system? Everyone on Medicaid, everyone on Medicare, everyone on whatever. Probably not. Not for a while. There's too many players fighting over that. So people are going to advocate. Elderly, women, and children. Those are very protected classes. Sorry guys, I'm not picking on the guys. I have 3 boys myself. Love them. But, you know, who gets favored? You know, the doors for the ladies. Women, children, you know, the resources go to them. We look at our state Medicaid program. A single father can't access Medicaid, but a single mother can. I don't get that one. That doesn't make any sense. It's just the way our society's been built on some of those principles of take care of our elderly, take care of our women and our children. And not that we don't, but we're gonna have to say, you know what? Maybe you need to take care of your grandma too. And you need to help your grandma with that smart technology. Yeah, goes into those societal stuff we talked about, that you're kind of imposing, getting into some values and getting into some things that people don't wanna touch. You had a question?
No, I was just thinking to try and get our
Yeah.
grandma to use the smartphone like that.
Yeah, well,
My grandma at least.
yeah, it's, and you know, I mean, he obviously is from the Bay Area and he loves a smartphone. I don't think it has to be the smartphone, there'll be other ways that things will be done. But, I don't know, it's easy to write an app and, for
My
some.
grandma still uses one of those phones
Dial
that
phones?
you get to.
Yes,
I was just gonna say, how do you manage to have a balance between profitability, because you know, a hospital is a business, and quality care? Because I think sentiment's been expressed, well, if this technology comes, it will save costs, but where's our revenue stream gonna come if we cut some of those tests and some of those things that bring revenue to us already? Does that make sense at all?
Absolutely, and that's the $1,000,000 question, literally, or probably trillion-dollar question. So, it's called the second curve. And you can look that up if you want to, but it's talking about how you're going from this volume-based business to going to the value-based, and it's when does that intersect? So you've got two completely different business strategies, but you can't just turn on a dime on that business strategy. It takes a lot to switch a business from one way to another. And the timing on that is when a hospital will either stay open or not. And quite frankly, and I was talking to the American Hospital Association today, I said, so any guess on when volume-based will go into play? Well, maybe 5 years. I mean, you don't even know when, you don't know how. You're playing by rules that you don't have the cheat sheet, you don't have anything to go by, so you're trying to guess. So, for us at Madison, why we affiliate with the University of Utah, one of the reasons why we affiliate with the University of Utah, you know, we're Madison Memorial, we're great. We're not a university teaching hospital. It has access to a lot of different research that we don't have access to. So you gotta think really outside the box. And say, hey, is there a way for us to get those ultrasounds for our doctors and use those without having to pay, honestly, I don't know what they cost. But if you go to buy a saw for a surgeon, well, maybe not a saw, but a drill. Let's use a drill. So our last drill was $50,000 that we bought. Go buy a drill at Sears. How much does it cost? $50, $100? A power drill? We gotta pay $50,000 for that thing. It's not that much different, guys. I mean, it's been FDA approved and all of that, but that's my concern about the markup on it. So even though a hospital can look at it and look at the different ways and just try and control the revenue stream and stay profitable, we don't get a choice in a lot of things out there. So I'm not sure, other than we're fortunate, we're a county hospital and some of this is the right thing to do, and so we're gonna do it. You know, that's the thing that's great about going into healthcare. You're taking care of patients and people. You can take people back to that. Sometimes you can win them over, but a lot of money and a lot of stuff out there that keeps against it. Yes.
I was just gonna ask, so a drill for a surgeon to use costs $50,000.
I'm pretty sure it's the right one.
Yeah,
I think it's 50. A little bit under. 45 or something, like 40.
Same thing like carpenters use like
Pretty much. I don't see a whole lot of difference. It's been a little while since I've been in nowhere, but actually I've never used a drill in my life, let me clarify that. But my point is, it is pretty much the same thing, except it's been FDA approved, which you don't want us to go buy the Black & Decker or the cheap whatever is out there. You want to know it's going to work and not break on you.
It doesn't cost $40,000 to build it. I can get a drill.
But the markup and the company that went through all of that, absolutely. Any other questions? I went over, sorry.
No, you're fine. Is it okay if a couple people have some additional questions to just talk to you all for, or how much
Absolutely.
time do you have?
Lots.
Okay.
Did you like that? I went to the boss.
So, we'll just, if you have additional
Oh,
questions.
the power's out at the hospital. Heck, I don't have to go. That's what I was letting them know. I'm like, what? Our power's out. Yes, I'm happy to stay. Thank you. Sorry to miss you. If you have questions, let me know. Thank you.